Well, good morning. My name is Hari Nathan. I'm the director of the Michigan Value Collaborative, and on behalf of the entire staff at the Coordinating Center, I'd like to welcome you all and thank you for joining us today for the fall semi-annual meeting. As we proceed through the presentations this morning, I'd like you to ask any questions that you have through the Q&A function on Zoom. Please do tell us your name and your hospital or PO affiliation. And we'll do our best to get to all the questions that we can. Due to time constraints, we may not be able to, but we will certainly follow up with you afterwards if we're not able to get to your question during the presentation. After the meeting is over, you will receive a survey from MVC and Blue Cross, and we'd ask that you please complete that. And in particular, as we've moved towards this virtual format due to COVID restrictions, we'd love to hear your feedback on how that's working for you and on any suggestions you might have as to how to do it better. So first, I'd like to welcome all of the hospital, physician organization leaders and staff, and a special welcome to our first-time attendees. We have two guest speakers today, and I'd like to start by thanking them for their participation as well. And those are Dr. Stephen Katayan from Henry Ford Hospital and Dr. Michael Danek from Ascension Genesis. We really appreciate both of them lending us their time and expertise. Our agenda this morning is 1.5 hours of presentations, starting with this welcome. Second, we'll talk about COVID-19 and what we can learn from MVC data about the pandemic. We'll then move on to two presentations about two new Value Coalition campaigns from MVC, focused on cardiac rehab and on preoperative testing. And then we'll finally wrap up with some conclusions and a preview of next steps for the collaborative. So let me start with a few updates from the Coordinating Center. Over the last 6 months, we've worked towards providing more frequent data updates, as well as increasing the frequency of push reporting. Since the last semi-annual meeting in May, we've issued updates for our CHF and COPD follow-up reports. We've issued updates for our sepsis report and our cardiac service line reports. And additionally, we've issued new reports on cardiac rehab utilization over PCI, TAVR, and CABG. We've also issued a sepsis report, kind of volume 2, if you will, and that's just been over the last 6 months. So we're trying to continue to issue these at a fairly rapid clip. And as always, we welcome your feedback and really rely on it to help make these reports more useful and better. So please let us know how we can improve these. Another major improvement has been in response to feedback that we got from a lot of the hospitals, which was that they would like to have specific comparison groups easily accessible to them. And so we've instituted both geographic and P4P comparison groups based on certain hospital characteristics. Those have been added to the registry so that when you look at your performance data on the registry, you can easily compare against comparable peer institutions. Finally, as I mentioned a few minutes ago, we have two new Value Coalition campaigns, which we have launched. We'll outline those for you today, and we'll again welcome your participation in those because we're very excited about those opportunities, and we think that that'll be something that many of you will be able to make valuable contributions to. We're actively working on a new COVID-19 service line. This will include both patients who are discharged with a diagnosis of COVID-19 as well as those who have undergone COVID-19 testing. And it's a little bit unique in the sense that it will include patients who might otherwise fall into our other service lines as well. We recognize that many of these patients, due to the complexity of the clinical illness, may actually have other procedures done which would otherwise be captured by the existing MVC service line. So the idea here is to be as inclusive as possible. And I think there will be many interesting and important questions that we can address using these data. Finally, we have gained approval for Medicaid data to be added to the MVC data set, and so we're actively working on that. And I hope that in the near future, likely in the early part of 2021, you will be able to access data on Medicaid patients as well. We continue to update the MVC registry on a monthly basis. The latest available data for Blue Cross Blue Shield claims and BCN claims include indexed admissions through May 31st with follow-up data through August 31st. For Medicare fee-for-service claims, we currently include index admissions through September 30th of 2019, and Medicare fee-for-service follow-up data through December 31st of 2019. And just as a reminder, we get Blue Cross claims on a monthly basis. We get Medicare claims on a quarterly basis with a lag that's determined by CMS. We know that the COVID-19 pandemic has inserted quite a bit of uncertainty into the operations of various organizations and institutions, including our hospital members who are participants in the P4P program. I'd like to remind everyone that program year 2020, because it relies on performance data from 2019 and baseline data from 2017, will be unaffected by the pandemic, but we are actively exploring ways in which the pandemic might impact program year 2021. I think it's safe to say that the jury is still out on this. We're certainly sensitive to the fact that many aspects of what we do on a day-to-day basis have been impacted and may in turn impact performance on the P4P measures. Because program year 2021 will rely on performance data from 2020, we do expect that there will be some impact of the COVID-19 pandemic. So we'll continue to actively look at this and try to advocate for the members in order to make sure that everyone feels that they're being treated fairly under the P4P program. At this point in time, based on the data that we have, we plan to proceed as normal with scoring for program year 2021, but we'll continue to monitor those incoming data and make any changes or at least recommend them to BCBS as appropriate. But we do want to offer a couple of new opportunities to all of our members, and that is that there will be bonus points that can be earned by attendance at both MVC semi-annual meetings, as well as arranging a virtual site visit for with the MVC Coordinating Center. And so we hope that even though there may be some variable impacts of COVID-19 that may impact performance, that this will allow an opportunity for anyone who's concerned about that to earn some extra points to try to mitigate the impact of COVID. So at this point, I'd like to turn it over to Chelsea Abshire from the Coordinating Center, who's going to talk to us about what we can learn from the MVC data about COVID-19.
Thanks so much, Hari. Hi, my name is Chelsea Abshire, and I am an analyst with MVC. And like Hari said, today I'm going to talk to you all about the new COVID-19 condition. So our new COVID-19 condition is a little bit different from our other MVC conditions in that it currently exists outside of the MVC registry. So we've put it outside of the MVC registry so that we can have overlap with other conditions. So Hari kind of got into this a little bit in his last talk, but basically, so if someone was hospitalized for a joint replacement as well as COVID-19 in the same 90-day window, they would be able to be in both conditions, which is a little bit different than how we normally do things. So the COVID-19 condition starts with patients' admissions from March 1st, 2020 and goes through present day, and currently only includes our Blue Cross patients due to the Medicare data lag, but we do plan to add our Medicare patients as we get the 2020 data for them. So in order for a patient to be included in our COVID-19 condition, they must have an inpatient admission to one of our MVC hospitals, and they also must have a confirmed COVID-19 infection. And we are considering someone to have a confirmed COVID-19 infection if they have one of the ICD diagnosis codes for COVID. So now I'm just going to get into a little bit of findings from an initial analysis that we did on this new condition. So overall, looking at the age breakdown, you can see that the majority of our patients are between 51 and 90 years old, with the majority sitting in that kind of like 61 to 80-year-old range. Again, these are only Blue Cross patients, so when we add in Medicare patients later, we might see some of these trends shifting in different ways, but more to come on that in the future. So in terms of comorbidities, 42% of our COVID-19 patients also are experiencing diabetes. 26% are experiencing CHF or vascular disease. 22% are also experiencing COPD. 16% are experiencing some sort of neurological disorder. 12% are experiencing a respiratory dysfunction or cancer. 9% are experiencing chronic kidney disease. 6% are experiencing some sort of cerebral vascular accident. And 2% are also experiencing liver disease. So anecdotally, we know that some of our more severe or high-risk COVID patients are those who are experiencing multiple comorbidities at the same time. So we sought to kind of quantify this in our own data and found that over 30% of our patients are experiencing 2, 3, or 4 comorbidities at the same time. And we even saw a couple patients who were experiencing 7 comorbidities all at once, which really is quite a bit. And we feel like those people are probably at higher risk for negative outcomes while in the hospital than our other COVID patients. So the COVID condition is a little bit different than our other conditions, and that when we're looking at episodes, we're looking at currently 30 and 60-day episodes rather than the normal 30 and 90-day episodes. We do plan to expand these episodes as we go forward once we have more follow-up period time, but right now we're looking at 30 and 60 days. So in terms of episode payments, and also hospital variation across our collaborative, you can see that there is really quite a large variation among our hospitals, spanning from just over $15,000 to under $40,000 per episode. Interestingly, you can also see that the 30 and 60-day episode payments really are quite close to each other and follow a really similar pattern. And in the next slide, we'll get into kind of why we think that's happening. So looking at the episode breakdown, you can see that really the majority of cost is made up in the index, so that little orange section. And of course, because when we're looking at 30 and 60 days, that index period is the same. So you see the costs are the same. But working to the next highest category, so looking at professional fees, you can see that in the 60-day period, the professional fees are a little bit higher on average, which you would expect. But really the difference here is only about $300. Again, confirming that really the majority of cost here is in the index. And we see similar patterns for readmission costs and also post-discharge costs. So 33% of our patients received some sort of post-acute care, and 16% of those received outpatient other. So outpatient other is anything like testing, screening, x-rays, anything like that. 9% received home health. 4% received some kind of rehab, so that could be inpatient or outpatient rehab, and only 2% went to a SNF. So in terms of outcomes, the median length of stay was 7 days, with a mode or most common length of stay of 4 days. 19% of our patients died during that admission, and 8% were readmitted. So this was just, a quick snapshot into the kind of data that we can provide for you all through this new COVID-19 condition. And we're just wondering what else you would like to see. So if you're interested in seeing reports, maybe at the hospital level or the PO level, or even at the collaborative level, and then also what kind of data you'd like to see in those reports, please feel free to reach out to the coordinating center with any thoughts or ideas you might have on this. So thank you so much. And now we have just a few minutes for questions.
Thanks, Chelsea. So we have one question coming through the Q&A. The first question is, how do you plan to risk adjust for COVID in secondary diagnosis fields for patients that are in different service lines, i.e. without COVID as primary?
So right now we aren't risk adjusting those patients. I believe that we would still include those people in the COVID condition going forward, but we'll have to look into that a little bit more and get back to you.
Thank you. So second question is, are we seeing a decrease in length of stay over the course of the pandemic?
So that's actually not something that we've looked into so far. That's really an interesting question, and we can definitely look into that going forward if that's something that's interesting to collaborative members.
And one last question coming in through the chat. Do you plan to remove COVID patients from other registry conditions?
We do not plan to remove COVID patients from our other registry conditions, but we do plan to add a filter on the registry so that if you wanted to remove those patients from your episode cost or anything like that, you'd be able to like toggle the filter on or off.
And one final question that's just come through. Are you able to tell why COVID patients are being readmitted?
Yeah, that is something that we would definitely be able to tell in the future, yes. So with that, I will turn it over to our MVC co-director, Mike Thompson, who is going to introduce our new cardiac rehab VCC.
Thanks, Chelsea. Again, my name is Mike Thompson. I'm the co-director of the Michigan Value Collaborative, and I'm thrilled to be here today to talk about our new VCC around cardiac rehab. So over the course of this presentation, I'll give a little bit of an introduction around our purpose for this cardiac rehab VCC, which you can see here. Talk about some of the work that has gone into launching this VCC and some of the data that we've been able to dig into over the course of the past year. And then I'll close by introducing our guest speaker, who is Dr. Stephen Katayan, who is a national expert in the field of cardiac rehab. We'll talk a little bit about the landscape of cardiac rehab moving forward. So to summarize the purpose of this VCC, we aim to equitably increase the participation in cardiac rehabilitation for all eligible individuals in Michigan. And I'll go into different facets of this as we move forward through the presentation. But first, I think it's important to get a broad overview of what cardiac rehab is, and Dr. Katayan will go into a little bit more detail about the different aspects of this. But from a broad perspective, cardiac rehab is an intervention that's multifaceted and includes different components like monitored exercise, diet, lifestyle, nutrition counseling, stress management, smoking cessation, and psychological and social support. And to be specific about what we're talking about when we mean cardiac rehab, we're referring to phase 2 cardiac rehab. Phase 1 is often in the inpatient setting, and what we're referring to is phase 2, which occurs largely in the outpatient setting. So there's substantial evidence on the benefits of cardiac rehab. Research shows first and foremost that attendance in cardiac rehab after an acute cardiovascular event like an AMI or some sort of cardiovascular procedure like a percutaneous coronary intervention or coronary bypass surgery lowers the risk of future cardiac events. It also has been shown to increase survival out beyond the discharge period and reduce the risk of readmission and rehospitalization. But beyond that, it's been shown to improve eating habits, facilitate weight loss, and encourage an overall healthy lifestyle. But despite a lot of this evidence, the uptake and participation in cardiac rehab still remains low and for a lot of patient populations that would stand to benefit. So over the past year, we started to develop these cardiac rehab push reports, and these have been in partnership with our other CQIs around percutaneous coronary intervention with the BMC2 collaborative, as well as some coronary bypass surgery with the Michigan Society of Thoracic and Cardiovascular Surgeons Quality Collaborative. We've also developed one around transcatheter aortic valve replacement. And largely these reports include your hospital's enrollment in cardiac rehab within a 90-day period for these specific conditions. But it also provides additional information on specific patient subgroups, trends in cardiac rehab enrollment over time, as well as where your cardiac rehab rate compares to others in the collaborative. Our first iteration of this was launched about a year ago, and we have since sent out a more updated version over the third quarter of this year. So included in a lot of these reports are where your hospital ranks according to the collaborative hospitals that partake in some of these surgical procedures. And for instance, if we look at the cardiac rehab after PCI, the overall rate of cardiac rehab enrollment is just above 30%. But if we look across hospitals, we see that cardiac rehab enrollment within a 90-day post-discharge period ranges anywhere from 10% to 50% across hospitals. And largely this pattern is similar across other cardiac procedures, including TAVR and CABG. I think what this shows more than anything is there's a great opportunity for us as a collaborative to learn from the hospitals that are doing well, and how do we disseminate these best practices to hospitals that are have lower cardiac rehab enrollment rates than others. Based on these data, we've spent a lot of time over the last year trying to understand some of the perceived barriers to cardiac rehab attendance. I think first and foremost, one that often comes up is around out-of-pocket costs for patients. Each session, there's a recommended 36 sessions for cardiac rehab, and each session comes with a copay. And so we're trying to explore opportunities around this with our payer partners. We can also understand that there are issues around transportation and distance to nearest cardiac rehab facilities. As you can see on the map here, which I highlight different locations of cardiac rehab centers across the state, you can imagine that in certain parts of the state, patients may have to travel very large distance to attend a cardiac rehab session, let alone 36 of them within a year period. And over the course of the coming years, we hope to understand more about these barriers and try to find solutions that we can use to disseminate across the state to improve the overall rate of cardiac rehab enrollment. I mentioned in the purpose statement that equitably increasing cardiac rehab is a major and primary goal of our VCC, and I hope these data highlight why. If we look at Black individuals across the state of Michigan, we see that cardiac rehab enrollment lags far behind other racial and ethnic groups within the state of Michigan. If we look at more of socioeconomic disparities, we can see that those that are dually eligible for Medicare and Medicaid, which is often used as an indicator for socioeconomic disparity, is about half of that of Medicare beneficiaries that do not qualify for Medicaid. I think if we're going to do the right thing here, which is increase cardiac rehab enrollment for all of our Michigan residents, especially those that lag far behind others in vulnerable populations, these are data that we need to continue to follow, and we will provide these data for each of you that hopefully we can understand where everybody stands and opportunities to improve cardiac rehab enrollment within those populations. Beyond that, we have our goal is to take the data that we find and distribute that in ways that are novel and new to our collaborative. This was a graphic that was developed by some of our coordinating center members, which is really highlighting different data points around cardiac rehab enrollment after coronary bypass surgery. The hope is that not only will these graphics and dissemination materials make it easier for you all to interpret and understand the data in a very easy way, in a way that you can disseminate to your partners within your institutions, but also ways that we can disseminate it to the public at large and other members of the community that may hopefully facilitate improvement of cardiac rehab enrollment across the state. So we've spent a lot of time over the last year getting this going, and we're really excited, but I'm very excited to have Dr. Stephen Katayan here as our guest speaker to talk more about the current and future landscape of cardiac rehab. After his presentation, there will be a few minutes for Q&A, so please enter any of your questions into the Q&A box, and I will help facilitate those at the end. Dr. Katayan is a member of the Clinical Bioscientific Senior Staff and is the Director of Preventive Cardiology at Henry Ford Hospital. He is internationally recognized for his research that investigates the role of cardiac rehab, which has demonstrated improvements in life expectancy, physical function, and quality of life. Dr. Katayan has helped form national recommendations on the use of cardiac rehab and continues to be involved in studies that investigate how exercise and testing and training assist in the diagnosis, treatment, and care of patients with cardiovascular disease. I'm very thrilled to have Dr. Katayan here, and we look forward to his talk.
Thank you very much, Michael, and my thanks to the MVC group for providing me the opportunity to speak. I'd like to cover these 4 points during my talk. Give a brief description again of cardiac rehabilitation. Talk a little bit about the national landscape as it applies to cardiac rehabilitation. Go a little deeper into the clinical effectiveness in cardiac rehabilitation, and address some of the barriers, current and future, that we have for cardiac rehabilitation, and some of the current strategies that we have in place at the patient, provider, and policy levels. So from a very high level point of view, as Mike mentioned, cardiac rehabilitation is traditionally up to 36 visits of supervised exercise. Every patient gets an individualized treatment plan as they go through. We spent a lot of time, and I'll mention this in the future, on the educational aspects associated with the treatment of patients with cardiovascular disease. A lot of the stuff that you would like to have happen in the exam room setting just doesn't take place due to time, and then all of this can take place in the cardiac rehab setting. I've listed for you on the left there people that are eligible for cardiac rehabilitation. Right now, I do want to highlight patients with heart failure. Only covered by, with CMS, only covered are those patients with systolic heart failure. Those patients with diastolic heart failure are not covered at this time. We're working hard to work on that group for reimbursement, but also patients with atrial fibrillation. There are 6 core components to cardiac rehabilitation as listed out here. We do assess patients before and after the program to look at behavioral outcomes, to look at clinical outcomes, to look at physiologic outcomes. As I mentioned, everybody gets at least 31 minutes of supervised exercise with each visit. There's dietary education. We work on tobacco abuse. Behavioral services is pulled in as needed, and medication and just general chronic disease management is incorporated as the overall program. I did mention patient education, and we deliver it in 2 formats. If patients come to our brick and mortar facility, we have 8 60-minute educational behavioral sessions, just as you would assume, covering the topics as I mentioned before, in a very behavioral atmosphere, a very behavioral approach. If they can't come to the brick and mortar or they're in our home-based program, we've taken these educational sessions and broken them into 28 audio PDFs. These have been very well received. I've given you the web link below. These are free. They're for any people in your institutions, your patients, your programs want to access these. You're welcome to. They're highly utilized, very well done, and actually they're in the process of being updated. But they're very short, and each covers a specific topic. So in terms of level of evidence, cardiac rehabilitation has been classed out as class 1 for all these different indications that I've listed here and that I've highlighted here in yellow: revascularization, angina, and ACS, and including heart failure. So it's well integrated into the care pathway for patients with cardiovascular disease. As a result of that, ACC, American College of Cardiology, and American Heart Association performance measures include referral to cardiac rehabilitation from both the inpatient and outpatient setting, and recently added enrollment into cardiac rehabilitation as a performance metric, as a performance measure as well. So here's the big picture in terms of utilization. Mike showed you some state data for utilization of or enrollment into cardiac rehabilitation in Michigan. This is the most recent paper from using CMS data for the US and looking at Medicare beneficiaries. And in the 2016-2017 year, there were 366,000 people eligible for cardiac rehabilitation, and only 24% participated. Our goal for 2022 has been 70% for the past 5 years. We are improving from the 14% several years ago, so we've made headway, but we're still falling way short of our target of 70%. So I've indicated with that big arrow, looped arrow underneath, that's the treatment gap that we continue to work to close. Of those people that do go into cardiac rehabilitation, not everybody is getting a full 36 visit dose. Only about 27% of the patients get all 36 visits. Right now, the median number of sessions attended is around 25 or 26, I believe. So there's room to improve there as well, because improvement is dose related. This is a slide from the MVC, and specifically, I just wanted to show that participation also varies by type of event and third-party payer. So you can see that if you look all the way over to the far left, regardless of type, we're running about 25 to 35% participation in cardiac rehabilitation. And as you break it down by index event, these numbers are lower for for acute MI and higher for the 2 forms of revascularization. So again, some target strategies that we can work towards in terms of effectively getting patients into the program. In terms of the effectiveness for cardiac rehabilitation, I've listed out here, it's a systemic treatment where exercise is a systemic therapy. It's not like many medications. It affects many other areas of the body than just the heart. And you can see we affect many of and favorably affect many of the targets that we'd want to improve as a result of being in cardiac rehabilitation. Everything from risk factors to behavior to clinical outcomes and even vascular function and an inflammatory effect. But I've listed to the top there from a patient-centric perspective, patients feel better. They experience less angina, less shortness of breath, less fatigue as a result of being in the program. We're able to improve their exercise capacity, not saying that they have to do more, but if they want to do more, there's a functional improvement in their exercise capacity as well. Mike mentioned, and this paper's a little bit old now, but Mike mentioned the effect of cardiac rehabilitation on clinical outcomes. We get about a 10%, 15% reduction in all-cause mortality, about a 25% reduction in cardiovascular mortality, and about a 30% reduction in rehospitalizations over 6 to 12 months. And this was a systematic review that appeared in Cochrane. But more importantly, I think you'll find this slide very interesting. This is the number needed to treat. So how many patients have to be seen to prevent one death, be seen in cardiac rehabilitation to prevent one death? This is a statistical approach. And you can see we've compared several of the secondary prevention strategies here for cardiovascular disease: antiplatelets, ACE inhibitors, statins, beta blockers, and cardiac rehab. And I'd make the argument, and others have made it as well, that this is cardiac rehab stacks up very favorably to these other therapies and gives further rationale for including it into the care plan of these patients, or the importance of including into the care plan of these patients. And this paper appeared in New England Journal, I think it was last summer. Well, as Mike mentioned, there are barriers to getting into cardiac rehabilitation. I break out the barriers at the patient level, at the provider level, and at the policy level. At the patient level, we have both patient-specific and medical issues that hinder patients getting into cardiac rehabilitation. I've listed for these here. Most of these will make common sense. Co-payment is an issue. We work hard on that. We've had conversations with providers along this way. We've made some headway with Medicare Advantage, but it is for many patients a barrier. At the system level, in terms of how cardiac rehabilitation is delivered, there are clearly some things, and I'm going to touch on these a little bit more, that we can do as a system delivery, both by program and system, and how we can do better at getting patients enrolled in cardiac rehabilitation. And I draw your attention to that third bullet, that we know that for every day after discharge from the hospital that lapses without contacting and aggressively trying to get patients into cardiac rehabilitation, there's a 1% decrease in patient participation in the program. So if we wait 4 or 5 weeks to reach out to these patients before scheduling their first visit versus schedule their first visit before they're even discharged, first visit might be in 2 or 3 weeks after discharge, those differences can have an effect. And there are some policy and payer things that we still have to work on. I mentioned deductibles and co-payments, and some patients are not covered. Some patient populations are not covered. 3 things I'd like to highlight in terms of system level things or strategies that could be used. First, we can use the EMR to leverage referral. More and more now we're using an EMR-driven automatic referral, especially through order sets, that the patient, and we're also using it as an opt-out function so that it's automatically checked. And I've shown that here with that little box that's checked below the circle of order set that says it's a general cardiology order set. And the person would have to uncheck the box to prevent the person from getting referred to cardiac rehabilitation. And this has helped greatly with referring patients to cardiac rehabilitation. I'll also say that a strong endorsement from the inpatient providers and from the outpatient providers increases participation and the number of sessions attended. So physicians, APPs, support staff, encouraging and recommending the patients to go to cardiac rehabilitation is important. Prior to hospital discharge, one thing that we've done here and are doing better now at Henry Ford, and should be an initiative that we're undertaking throughout the state, is having somebody from the outpatient side or the inpatient side serve as a liaison to touch base with the patients formally for 2 to 5 minutes and just say, we want you to go to cardiac rehabilitation. We're going to schedule your first visit, secure the correct contact information, and make sure the referral is in the system. There's other information we can touch base with if the patient wants to talk more, but this liaison contact, kind of starting the handoff from inpatient to outpatient, really drives outpatient participation. And just to give you some Henry Ford data here, I've shown here the 2017 and 2018 data for total number of visits at the Henry Ford main campus phase 2 cardiac rehabilitation program in Detroit. When our inpatient liaison contact was not operating as efficiently as we liked, at the end of 2018, this is number of cardiac rehab visits at main campus. At the end of 2018, we took a concerted quality improvement effort to restructure, to re-energize our inpatient liaison approach, getting somebody over to the hospital 4 to 5 days per week. We did that at the end of 2018 and the beginning of 2019. And as you can see, we increased by almost 1,000 patient visits over 2017 and 2018, the number of people that we were seeing in the outpatient setting in phase 2 cardiac rehabilitation. We're very pleased with this. Another strategy is trying to meet patients where they live, dependent care, return to work, transportation issues, time services are offered. So in 2016, we offered our home-based cardiac rehabilitation. Actually, it's a hybrid program that combines both center-based and center-based and remote program. It's a telehealth-based approach. There's good evidence. There's a scientific paper from AHA on this that supports the alternate forms of delivery. We've been doing it from 2016. At present, we're doing about 100 to 110 telehealth visits each month with a group of our patients. It represents about 15 to 20% of our inpatient our main campus program. You can see in the upper left here, using the patient's cell phone, and surprisingly, or maybe not surprisingly, about 92% of our patients in Detroit do have a cell phone and access to the exercise equipment through some unique ways that we have to go about thinking about it. But you can see an image in the top left what the patient sees on their cell phone. To the top right, you can see what the provider sees on their screen as the patient's exercising, let's say on a treadmill or something like that. We don't use the cone of silence, but we do use a HIPAA compliant pathway that allows us through MyChart in Epic. There's a HIPAA compliant virtual private network that we can go through. We're going to switch to a new platform in January that will allow us to conduct 4 or 5 patients at the same time, have personal conversations or have group conversations at the same time, and patients will be able to drop in anytime during an hour rather than a scheduled appointment, anytime during an hour for their 31 minutes of exercise. Currently, this program is covered by HAP and Blue Cross Blue Shield, and again, we rely heavily on our web accessible, internet accessible education programs to deliver the patient education. We're very pleased with this. It's the only program, there's one other program now at UCSF in the country that's mirrored off of ours that's doing this. We're very pleased with this. This is where we think we're going to really help shrink the gap in treatment over the next 5 to 10 years, treatment gap that exists for cardiac rehab. Finally, I'd like to just cover what's the pushers and the pulls, what's the driving forces and restraining forces, just to provide this for cardiac rehab and do a summary. Clearly, the biggest pushes right now is there's some things we can do in cardiac rehabilitation that we're working on. Telehealth, I mentioned. There's some right sizing we can do in clinical surveillance, do group orientations as patients get recruited into the program. We don't have to do one-to-one orientations. Things are much more data-driven now from an inpatient liaison circumstance. We can use our EMR to collect data and also refer patients. There's good momentum in the US right now in terms of enforcing or encouraging cardiac rehabilitation at both the performance measure and also at the federal level with funding from NHLBI and ARC and NIA. And we're also getting, one could argue that we're getting what we wished for. After being in the service now for almost 40 years, clearly we're at a good stepping off point to really advance cardiac rehabilitation. And then on the barrier side, this COVID, just like you had mentioned before, COVID has thrown cardiac rehabilitation into a new level of craziness. Whatever variability that was existing between programs before has increased because of COVID. We have smaller class sizes, increased number of classes, cleaning everything down, staff burden in terms of having to take care of all this. So these are some things that we're having to work on both scientifically and operationally. Shorter length of stay due to COVID and shorter length of stay in general are pushing people out sooner. So we're trying to capture these patients. There still is a lot of dogma in cardiac rehabilitation that we have to overcome in terms of this inertia, getting providers to be resistant, to overcome the resistance to change. This speaks well to the MVC in terms of getting people together and talking about these. And I've mentioned some of the patient and policy barriers that I spoke about earlier. So Mike, I'll stop there and willing to entertain any questions that come up.
Great. Thank you, Dr. Katayan, for this really great summary. I think you highlighted a lot of opportunities that we can leverage as a collaborative to really get to where I think we all want to go, which is the targets that we've set out as a group within MVC as well as nationally. Do we have any questions from the audience?
Quite a few questions coming in around episode spend, so we'll start there. Has there been an analysis that shows episode cost is less for patients that use cardiac rehab? Clearly, the clinical outcomes are better. If the episode cost is less, then maybe the payers would be willing to facilitate with lower/no patient copays.
It's a great question. I don't know as of any specific analysis looking at 90-day episode spend. I know that there's a considerable amount of evidence that shows that a significant benefit of cardiac rehab is reducing potentially preventable readmissions, and I think that's where, if you look at kind of cardiovascular episodes of care generally, a big kind of piece of why some episodes are high cost are related to readmissions. Whether the extent to which those occur within a 90-day window, I can't really speak to. I think we'd be happy to look at whether or not what effect there might be, but I think. And Dr. Katayan, I don't know if you have a sense on, where, cost savings may occur for patients. I know rehospitalization is obviously a big one. And, if there's a specific time at which we start to see that signal may help to think about that.
So not much more to add, Mike. You did a good job answering the question, and it was a very good question on that specific topic. But I will say that we would like to think that we're looking at after 30 days in terms of starting to have an effect on maybe even after 30 or 45 or 60 days for the, so to speak, dose of cardiac rehabilitation to have its effect or start to have its accumulated effect on the biology of the disease or the biology of the problem. So a 30-day window would probably be too short of a window to consider for let's say, a reduction in hospitalization. Although there might be some because of the disease management aspects of cardiac rehabilitation, certainly within the first 30 to 60 days.
And just to add to that as well, I think, another piece that, we've been trying to get to from the population health perspective is preventing readmissions or preventing downstream admissions from occurring in the first place. And if we think about, recurrent cardiovascular events, preventing those hospitalizations from even occurring while it may not appear within that 30-day window, those would be counted as episodes down the road. And so I think it's, preventing those from occurring is what we're also interested in achieving.
Another question, and this one's directed to Dr. Katayan. How did you go about establishing the inpatient liaison process? What stakeholders were involved, and how were the individuals chosen to make phone calls to the patients?
So let me answer the second question first. The phone calls, the reach outs to the patients are done from the outpatient staff in cardiac rehabilitation. They're most familiar with insurance issues, working through barriers that patients might have with transportation, answering specific questions about cardiac rehabilitation. We encourage our APPs and physicians or providers here at Henry Ford, just get the patient to us. Don't get caught up in things such as insurance and transportation. The first part of your question about the liaison is very good, and I'll be very honest, it's a work in progress. So there's not a perfect answer, but we've used stakeholders, physicians from the cath lab, administrators. We've used APPs from the cath lab, nursing staff on the floor, head nurses or nurse administrative managers on the floor, staff from the outpatient side. We've really tried to get everybody involved in the process. Now, I will say that we're very sensitive on the outpatient side about the burden that the inpatient staff has to carry. So we have tried to free up our staff to get over, the outpatient staff to get over there at least once a day by at least one staff person to really take care of this inpatient liaison. Now, we can't be there 24/7, so we have to rely on the discharge APPs from the cath lab, or potentially some of the floor nurses or some of the things that go on the floor, and in some cases the cardiology fellows. So we do pull them into the process, but to decrease the burden on them as much as we can, as much as we could, we do rely on the outpatient staff to try and make at least one day visit, a visit a day over there to the inpatient side for, let's say, 4 to 5 hours to go through the cath lab and go through the general cardiology units.
Great. And if we can just follow up on that slightly, Dr. Katan, are you able to share any sense of the patient experiences with the program? Meaning, are there aspects that patients have found value in compared to others?
So really, really good question. Clearly, patients respond to feeling better. And we've learned to clue them into noticing it sooner. So we tell patients, and we'll go through their data with them. Are you experiencing less shortness of breath? Sleep habits improved, less angina, fatigue less? Can you do more? Cluing them early on that these are clues that this is what cardiac rehab is doing, helps lock that in and solidifies it for them. And we share their numbers with them. You were doing this much on the bike before, or the treadmill. Now you're doing this much, and your heart rate is no different. You're doing it at the same level of intensity, but you're doing more work. And so we clue this into this early on, and they appreciate that. The other thing that happens, and as you would expect would happen, is that they get themselves around talking to other patients with their similar types of problems. So whether it's helping with socialization, whether it's answering questions, making friends. Some of these people will go out for lunch or come early and have conversations, stay afterwards and have conversation. There is a socialization or behavioral aspect that helps with these patients. And we know it helps with depression. So that improves behavior as well. So we notice those types of things go on. For patients to see their blood glucoses go down, their blood pressures to go down, we clue them into those biological adaptations as well.
Great, thank you, Dr. Katan. And one final question for you, more specifically on the post-discharge call. Can you share a little bit of information about what the RN specifically focus on? Are they touching on medication reconciliation?
So MedRec may not happen. So we cover all the things that you'd want to, not all. We would cover most of the things you would want us to happen on that first visit, because there's a chance that they haven't talked to anybody since hospital discharge. So symptoms, when's your next appointment with your scheduled providers? Those are all covered. Medications may be covered in terms of getting them started in rehab. We might not do MedRec right then, but we would do it on their first orientation visit, which will probably happen 2 to 5 days, 2 to 7 days after that phone call. But if they need refills on the prescription, we're reaching out. So there is a fair amount of chronic disease management that goes on by the nurse or the exercise physiologist that reaches out and does that first phone call. That could happen 2 or 3 weeks after discharge. But then there's also the practical things that we'll go through in terms of risk factors. We start that education, symptoms, recognizing their symptoms, getting them scheduled for first appointments, those kinds of things.
Well, thank you so much, Dr. Katayan, for your time. I think, I hope we all learned a lot. I know I did, and I appreciate your time and expertise on this matter. And I'm sorry we weren't able to get to all the questions. And again, if you please, if you have questions, even throughout the rest of the meeting, please put them in the Q&A. We will address them as a coordinating center and reach out to you. So be sure to put your name and your affiliation in there so we can get back out to you. But as you can see, we have such tremendous expertise within the state of Michigan, and we hope that we can leverage that expertise and leverage the collaborative to improve improve enrollment in cardiac rehab. So thank you again for your time, and I appreciate you joining us.
Thanks, Mike. I appreciate it.
So now I'll turn it over back over to Hari. He will be introducing our next new VCC around preoperative testing.
Well, I'm really excited to talk to you about another new VCC that we're launching at the coordinating center. I think there's a lot of opportunity here for us to make an impact across a broad swath of patients undergoing elective surgery. The purpose of the MVC preoperative VCC is to reduce the use of unnecessary preoperative testing for surgical procedures, to improve quality, reduce cost, and improve the equity of care delivery in Michigan. So why do we care about this topic? The Choosing Wisely guidelines advise that we should avoid routine preoperative testing for low-risk surgeries without a clinical indication. And this is based on a fairly large body of research showing that routine testing for low-risk surgery is not associated with any impact on patient outcomes. And in addition to the potentially wasted money that's spent on the initial preoperative tests themselves, those tests can sometimes lead to a treatment cascade where perhaps a slightly abnormal laboratory value leads to another test, and so on and so forth. So there's potentially a cascade there that could be both expensive as well as lead to significant patient harm. Multiple publications have demonstrated that these types of tests are really unnecessary. There are also multiple society guidelines that have suggested that for these types of low-risk procedures, routine testing is not necessary. But as is often the case, publications in the medical literature alone are usually not enough to drive practice change. And this is a phenomenon that we see across the spectrum of low-value services, and preoperative testing is no exception. So we decided to start with what we know. We used existing MVC conditions, existing service lines. These are procedures that were chosen because they are typically done on an outpatient basis. Generally, they are elective. Typically, they're associated with a fairly low rate of perioperative complications. And as such, for the majority of patients, extensive preoperative testing really should be unnecessary. So we decided to look at laparoscopic groin hernia repair, at lumpectomy, and at laparoscopic cholecystectomy. These are very common procedures. And so part of the rationale for choosing them was that even a small impact can have a large overall effect on our spending on preoperative testing. In the United States, about $18 billion are spent annually on preoperative testing. When we look at the three service lines that I just mentioned to you, just in MVC data, so just including the payers that we cover, in the state of Michigan alone, we see that there's annually $3.7 million spent on preoperative testing. 1.8 million of this is accounted for by cholecystectomy, 1.1 million by lumpectomy, and about $750,000 by groin hernia repair. So clearly here, there's a big potential impact that we can have, as I said, even by just making small decreases in the use of unnecessary testing. I'll show you some data now from the collaborative to just give you a sense of how wide the variation is and what the potential impact of this initiative can be. So this demonstrates MVC hospital-based testing rates across those conditions that I just mentioned to you. And you can see that some hospitals test relatively infrequently, about 30% of the time, whereas others test almost 100% of the time. And whenever we see variation like this, we see a potential opportunity to learn collaboratively and then to improve. If we look at preoperative testing payments, again, we see similar variation where some hospitals on average spend $300 and others spend significantly more than that, 74% variation. And here, I think the lesson to take home is that there's a potential to save significant amounts of money, both per patient, but then in aggregate, if you think about how many elective surgical procedures we do in the state of Michigan on an annual basis, that's a large number of patients by which to multiply any potential savings. There are some differences by condition. So again, if we look at the three conditions that I've outlined for you, you can see that across all three, there is significant variation, but there's more variation in some conditions than others. If we look at lumpectomy, for example, the lowest testing rate hospitals are less than 10%. The highest testing rate hospitals are greater than 80%. I think the lesson here, though, is that there is not a flat curve for any one of these procedures. So for every single one, there's significant variation that's occurring in preoperative testing rates. And this particular one, I should note, is for EKG utilization. And so similarly, when we look at other specific tests, we see large variation. And so here we've summarized across a variety of different preoperative tests what that variation looks like. So you can see for EKG over towards the right-hand side, and this is what I presented on the previous slide, we see that for cholecystectomy and for lumpectomy, the rates of use are relatively higher than for hernia repair. Depending on the procedure and depending on the specific preoperative tests, the utilization rates are significantly different. So again, there's an opportunity to learn here. There's an opportunity to learn about why there's variation across different hospitals. There's an opportunity to learn about why there's variation across different procedures. And finally, there's an opportunity to learn about why there's variation according to the specific test that's being ordered. And so what are the goals of the VCC? Well, first, we'd like to develop hospital and PO level reports in order to feed back to you what your performance is on these various metrics and to then allow you to benchmark compared to peers. And I think that it's always difficult in these situations and using administrative data to know, well, what's the right rate of preoperative testing for some of these procedures? And I think benchmarking to peers can be very useful in order to understand where you are along that caterpillar plot. And certainly if a given institution or a physician organization is at one end or another, there probably is an opportunity there to look at processes and look at selection criteria for preoperative tests and to potentially make some improvements. And in addition to expanding to more service lines beyond the three procedures that I've described to you, we'd like to both focus on specific tests in terms of understanding that cascade of procedures and testing that can happen. For example, an abnormal EKG, which then leads to a stress test, which then potentially leads to a cardiac catheterization, all of which may be unnecessary if that initial test wasn't ordered in an inappropriate fashion. And we'd like to also expand to other preoperative tests that we may be able to learn about. Of course, we want to make sure we disseminate the information that we learn as effectively as possible, and we'll be using our work groups, which are already a well-established and very successful way for our members to interact. We'll be using blog posts to share with you what we learn as we go, and we hope that we can facilitate networking amongst the hospital and PO members themselves in order to share best practices and in order to work through some of these challenges. We see this as potentially being a very highly collaborative venture, and we will certainly be learning a lot, and we want to share that with you, and we invite your active participation to help us with this and to share what you're learning as well. So if you are interested in getting more involved, please contact us at the Coordinating Center. We would love to have your active involvement as we develop this, and you may decide to nominate a person from your institution or a representative from your hospital PO who's not the usual MVC site contact. That's absolutely fine. Anyone who is interested in this space and has some expertise or just curiosity about it is more than welcome to join us, and we can figure out ways to involve them. And especially now, as we're doing virtually everything by Zoom, we certainly can involve you in our periodic meetings about this and make sure you're up to date. In the spirit of learning then from our members, I'd like to introduce our guest speaker. Dr. Michael Danek is the Department Chairman of Anesthesiology at Ascension Genesis. He began his training at Michigan State University College of Osteopathic Medicine and Henry Ford Hospital in Detroit. He's actively engaged in patient safety initiatives, including those working on optimizing patients for surgery, as well as multimodal pain control. He also was very active in a number of community projects aimed at expanding the care for and prevention of opioid use disorder. He served on boards for the Michigan Society of Anesthesiology, for Powers Catholic High School, and the National Board of Foreign Medical Education and Accreditation. So Dr. Danek, thanks so much for sharing your time and expertise with us today, and I look forward to your presentation.
Thank you very much for the introduction, Ari. Appreciate it. When I saw the data from this, it was really interesting because I was surprised at the variation. From my standpoint, everyone should be doing the same thing already, but obviously it takes time to make changes. The variation is for multiple reasons. And I think it's because everyone thinks that their patients are sicker than others. And there's cultures of institutions that just want to have tests because they fear cancellations. So adjusting for all that is really necessary. I also think that there's going to be a lot of questions about stratifying that data out. And I don't think we have that information yet. So we'll have to hold tight a little bit. We'll have to wait to see if it stratifies out for obesity or age or other comorbidities. And that'll take some time. But to start the lecture, let's just say this is, we're going to determine if something's a low-risk surgery or if the patient has red flags. And this is how we approach every patient. And I think we've established very much so that the gallbladder surgery, the hernia surgery, and the lumpectomy is in fact low-risk surgery. It's ambulatory. For the most time, people are coming in and going home without any complications. I'd also like to say that these procedures are actually a little bit more advanced than a cataract surgery or an endoscopy. There's more hemodynamic changes that go with it, and that can be concerning. Especially as an anesthesiologist, sometimes I'm more worried about the anesthesia itself than the actual surgical procedure. And so when you have a general anesthetic, you have lots of hypotension, reflexive tachycardia, you have respiratory impairment, and that's all just going to sleep. And then on waking up, you have tachycardia, supply-demand issues, and risk for bronchospasms. So making sure you identify the patients that are high risk for those is extremely important. Laparoscopic inguinal hernia repairs. There's minimal fluid shifts, there's minimal changes in tissue, and the risk of bleeding is very low. There was a study in Sweden that looked at about 570,000 patients, and mortality was less than 0.004%. And when you look at certain complications, it is basically based on ASA score, age, emergency, diabetes, and smoking. And those are things we look at already. And here, if you look at the data, really, death is extremely low, and pulmonary and cardiovascular complications were well below 1%. Most of the complications that do occur are surgical complications such as wound infection or bleeding, and those can be easily managed, and pre-op testing is not going to help stop those. Lap choles. Now, I always consider this a little bit more of a bigger surgery, if you will, but it's still low risk. The perioperative mortality is less than 1%, but because you have so much insufflation of the pneumoperitoneum, that can make some more respiratory changes. There's other questions too, like what about pancreatitis? Is there a common bile duct that's obstructed? And in these cases, it's not an elective surgery, it's more urgent. So we're not really considering those in this data. And just to show that these studies have been done to show it's low risk, another one from Sweden shows that less than 0.15% actually had mortality. And most of the time is with ASA scores that were greater than 2. Finally, the third surgical procedure that we're looking at is lumpectomy. And I believe with this data that we're looking at simple lumpectomies that are either sedation or a general anesthesia with LMAs or endotracheal tubes. And that LMA or endotracheal tube can change some of the hemodynamics, and it's based on surgeon preference often. But these are lumpectomies when you are taking either the nipple and the breast tissue, but you're not really going in for all of the lymph nodes, and you're not taking off the pectoralis major and minor muscles. There's lots of data on this that came out in 2007 from the Annals of Surgery, and it basically said that for lumpectomies, there is no real cardiac risk. And if you look at the very top, 30-day mortality was 0 for lumpectomies, and for cardiac events, it was 0. And if you go down that whole line for lumpectomy, it is clear that it is a low-risk procedure. So how do we start to determine who is at risk during these low-risk procedures? Because people do have red flags, and trying to identify them is crucial. So the first thing is that we look at the ASA scores. If it's an ASA 1, they're healthy, no testing. ASA 2, relatively healthy, controlled hypertension, maybe controlled diabetes, a smoker. So they're relatively healthy, I don't need testing on them. ASA 3s means that they have diabetes, high blood pressure, COPD, morbid obesity greater than 40. Sometimes they have reduced ejection fractions. These are people who have problems and might need further testing. ASA 4s, those people are going to be admitted. No one who is an ASA 4 is going home. And other ways to check for surgical risk are surgical risk calculators. There's many out there and can be useful in many different spectrums. However, for low risk surgery, the H&P, the history and the physical, is the most important thing that you can do. Whether you obtain the patient's story from a phone interview, or whether you're seeing them the day before surgery or the morning of surgery, that H&P is the most important thing. And when you're looking at that H&P, the information you really want to look for is on that revised cardiac risk index. You're looking for ischemic heart disease, congestive heart failure, cerebrovascular accidents, diabetes, chronic renal failure with serum creatinines greater than 2, and then if they're having a high or medium risk surgery. So low risk surgery, and if they don't have one of those first 5 things, I don't need much more testing on that patient. So looking at this data here, you'll see where we do a good job. And looking at cardiac stress tests, echoes, and pulmonary functions, those look like they're the most underutilized test. And the reason I think that's the case is because there's lots of guidelines out there, and there's lots of gatekeepers to make sure that those tests aren't ordered unnecessarily. Just in JAMA of this year, they said, unless you have these symptoms of acute coronary syndrome, heart failure, the tachydysrhythmias, and unless you're having major surgery, you don't need further testing. We've also had this, I know you can't read it, but we've also had this very nice logarithm from ACC-AHA that essentially says, unless you're having chest pain, shortness of breath, and if you're able to walk 4 miles per hour, if you're able to go up 1 flight of stairs, if you're able to do vacuuming at your house, you don't need a cardiac test for these low-risk procedures. Now, on the flip side, there's some people that are detractors and say that METS is somewhat subjective. And if you ever had patients, you sometimes look at them and you say, there's no way you play tennis 2 times a week. There's no way you ride your bike 10 miles. And so that subjective questioning can cause a problem, but I think that's only a concern in intermediate and high-risk surgery, not in low-risk surgery. Pulmonary function tests are also not overutilized, and that's because everyone in the community really understands that you just need them for lung resections. If someone is coming in for a low-risk procedure but has multiple sclerosis, scoliosis, myasthenia gravis, and they're having exacerbations, then I might be concerned, and then I might get some more tests, but that would be patient-specific. Blowing away dollars was a major study that was done back in 1997, and that one has really helped to decrease PFTs. Now, where do we not do that good of a job? And this is really surprising because the CBCs, do we need them for any of these patients? And the question is the pre-op arena the time to be screening patients for anemia, or is it the time to be screening patients for renal dysfunction? Perhaps, but most of this should be done as an outpatient in the primary care setting, not for a surgery-specific procedure. So CBC, I don't need a complete blood count unless it's a high-risk surgery or I expect a lot of bleeding. For anemic patients, unless they're symptomatic, I don't need it because I don't plan on giving blood to any of these people unless their hemoglobin goes below 7. Extremes of age, there's recommendations that people over 80 might be more anemic than others, but it's patient specific and you can diagnose that the day of surgery if necessary. I only need a white count if I think there's an active infection, and I only need platelets to see if they're bleeding and not clotting. Another issue is the EKG, and the recommendations are to look at the likelihood of cardiovascular disease in a patient. So if they have diabetes or a smoker and they've had a previous MI, then yes, I might want that EKG. The risk of the surgical procedure, for these we've already stated that it's not necessary. And will this EKG change my plan? My questions for low risk procedures are this: do you have any chest pain? Do you have any new shortness of breath? And did you walk in here? And if most of the time you look at them, they say we're fine, they can go to surgery. And the evidence is there to prove it as well. Other people at Mayo just this year in April said obesity might be an indication for an EKG. That's still being looked at, and it may be necessary, but it's not going to change your plan. And if it's not going to change your plan and the patient isn't having symptoms, don't get it. There's been plenty of studies out there. Dr. Tremper back in 1997 showed that ASA 1s and 2s, and when it's low to intermediate risk surgery, there is no difference in outcomes. There's also been plenty of studies that show that whether you have a bundle branch block, either left or right, it's not going to change surgery. And finally, the ASA guidelines, 2012, time flies. They say you only need an EKG if they have active cardiovascular disease, respiratory disease, or it's a high-risk procedure. And these EKGs are good for 6 months. In the elderly greater than 80, there may be some reasons to get the EKG, but the Society of Geriatrics says elderly could be 65, and I disagree with that. I know plenty of 65-year-olds that can be very active, and if they're active, they don't need an EKG for low-risk procedures. And down there, you can see that age. As age doubles, you get an increase in MIs, but still well below 1%. A basic metabolic panel, I don't need them, especially if there's an ASA 1 or 2, and it's the low to intermediate risk surgery. If someone has renal dysfunction, liver dysfunction, or if they're on diuretics and I'm worried about hypokalemia, then I'll just get a potassium. I don't need the whole panel. The Society for Geriatrics states that if you're over 65, they want creatinines on everyone. I don't think that's absolutely necessary. And here's the article that they talk about it. They say the American Geriatric Society recommends that all elderly patients have a creatinine test before surgery. But in the following paragraph, and I'm going to read this because it's important. Over the past few decades, a number of studies have highlighted the relatively low yield of routine perioperative test screening and the high aggregate costs from both the direct cost of tests and the subsequent studies for abnormal results. The reports have shown that many of the screening tests produce low rates of abnormal value in asymptomatic patients, are unlikely to change clinical management for the patient with abnormal values, do not strongly predict or adverse outcomes, or are subject to a combination of these limitations. So essentially that says we don't need these screening tests for low procedures. And the American Society of Anesthesiologists also says that we don't really need them, but if there's extremes of age, you might want to look at them. So the moral of the story is, if I have a geriatric patient, I'm going to examine them for risk factors, not for just their age alone. Urinalysis, we've actually gotten a little bit better with this at our hospitals. Essentially, we only get a urinalysis for pregnancy exams. Other than that, if there's a risk of a UTI, then we'll go ahead and get it. Chest x-rays, once again, if it's not going to change your plan, you don't need it. High-risk surgery, yes. COPD, there's been plenty of studies that show it doesn't make a difference, and obesity itself can lead to just abnormal findings, but a screening exam is not necessary for surgery. So I don't need that, and I only get a chest x-ray for low-risk surgery if the H&P shows active symptoms of pneumonia or active CHF. Finally, coagulation studies. For low-risk procedures, it's not needed. The only time you need coagulation studies is if the patient has bleeding disorders or if there's a problem with warfarin, liver disease. But if it's a low-risk procedure, it's not indicated and not necessary. And there's lots of literature to show that there's false positives and negatives in PT, PTT, and INRs. So, and once again, if you're doing regional blocks or if you're doing multimodal pain management with transabdominal plane blocks, you don't need coags to do those. So in conclusion, I think the H&P is the most important exam. Low-risk surgeries do not need preoperative lab testing, especially in asymptomatic individuals. And high-risk patients undergoing low-risk procedures may need evaluation, but they need specific testing, not overall massive amounts of tests, which surgeons sometimes order, anesthesiologists sometimes order, PCP sometimes order, but the evidence is there that we don't need to be doing that. That's it, Ari. Right at 15 minutes.
That was fantastic. Thank you for that overview, and thank you for your insights as a clinician who makes a lot of these decisions. That's really helpful to hear. I think we have some questions.
So first question that's come through for you, Dr. Danik, is that Medicare recently removed the HMP requirement in the 30 days prior to a procedure. Have you seen personally any changes in physicians' decisions in performing HMPs or ordering pre-op testing?
I have not seen any changes yet. While they've removed that, I know that at most institutions you have to have an HMP completed within 24 hours on the chart. And we're still going through the HMP, whether it's been filled out by a preoperative nurse. We still have to do our examination with the heart and lungs, and I haven't seen any changes as of yet, at least.
And related to that, you mentioned during your presentation that pre-op testing variation is often due to hospital culture or physician training. Have there been any programs that you've seen that have addressed this and ultimately helped reduce pre-op testing rates?
I think it's been done at some of the major institutional settings where they have pre-op clinics. The pre-op clinics have really helped to drive down testing, but at many community hospitals, they're just not financially viable. It's very difficult to pay someone to staff a pre-op clinic and to see patients. And low-risk procedures, I wouldn't even ask for them to come into the pre-op clinic. I think this conversation here with the Michigan Value Collaborative will start to make some difference when we start telling or start showing the clinicians what their data is. When they start realizing that their institution is ordering EKGs on everyone and no one else is, that is where we might see some change.
Yeah, I think those are great points. As time goes on and we see whether there is an impact of this new CMS rule in terms of some of these patients not getting a preoperative H&P because it's not required by CMS, it'll be interesting to see if that then is associated with a lower rate of ordering all of these tests. I think the other issue that you highlighted is that there's so many different ways that this is done. Whether there's a centralized preoperative clinic or whether it's the operating surgeon ordering this or whether there's an anesthesiologist ordering this. And part of the process here for us is to really understand what all of those different models look like. And we certainly need the collaborative's feedback on this. So you can tell us, how do you do things at your institution? So we can start to see if some patterns emerge in terms of is a particular way of doing this associated with a higher rate of overutilization? Is that potentially an avenue to try to make an impact on this?
And Harry, a question directed to you and MVC. Will the pre-op testing data that you displayed be available at some point in the MVC registry or other MVC reports? And if so, what will these reports be looking to contain? Yes,
our goal with this VCC and with the other one is to really give you as much feedback and as much data as we can. We've just gotten started on this in the last 3 months, and so we want to make sure that the data are thoroughly vetted before we send you those types of reports. As to what it will contain, well, certainly we have our ideas, but we want to hear yours. So if there are certain elements that you want us to include, let us know. We're more than happy to do that. We certainly, if you want to reach out to us, even before those reports are ready for prime time, if you would like for us to give you some preliminary feedback on what your institution's data look like, we're more than happy to do that and to work with you to try to explore some metrics that may be useful. We'll learn a lot from that because more than likely your suggestions will end up getting incorporated into the final report. So those reports are likely to look more or less like some of the push reports you've seen in the past, but exactly which elements are included is totally malleable depending on what you would like to see.
Great. And if we can just round off this section with one final question that's come through from Sharon Kellen. Can you share some information on when the ASA is determined? Is it in the workflow prior to pre-surgical testing?
Our ASA scores determined when we're examining the patient right in the preoperative area before surgery. And that's when you're taking all of the different H&P history, and it's determined right there. You can kind of have a feel for it before they get there, but we determine it right there. One of the nurse anesthetists or the anesthesiologist will make that decision and then communicate it to everyone else. I see some other questions. These logarithms are available. The hardest thing is that people don't like to follow them because there's always that one case they had, or there's that one time they got burned. But the logarithms are out there and they're very easy to follow. But when you do have an outlier, you have to have a go-to person to make those decisions because the variance at practices just between one anesthesiologist and another varies just as much as a surgeon's preference does for a case. And COVID-19, I think it will be an issue going for, even in 10 years, it's going to be a question because there may be pulmonary function issues with COVID-19.
Great. Well, Dr. Danek, thank you again. We really appreciate you joining us and giving us a great talk and some great answers to the subsequent questions. And we look forward to working with you very closely as we continue to work on this VCC.
Great. Thank you very much, Harry.
So to help close us out today, I'd like to introduce Debbie Evans, who's our Site Engagement Manager at the Coordinating Center, and she's going to talk about some next steps for the collaborative.
Thank you, Harry. I'd like to thank everybody today for attending our virtual semi-annual meeting. We really appreciate you taking the time out of your day to join us. A really special thank you to Dr. Katan and Dr. Danek for presenting their expertise and their insights on our current Value Coalition campaigns. To briefly recap, so MVC is focusing to equitably increase participation in cardiac rehabilitation for all eligible individuals in Michigan, and we shared some high-level data that the group has reviewed. Dr. Katan shared evidence to the benefits of cardiac rehabilitation, pointed out some of the treatment gaps between referral rates and patients actively receiving cardiac rehab, and then spoke to some of the barriers faced by patients and how Henry Ford have worked to address these. The Michigan Valley Collaborative has also opted to reduce the use of unnecessary preoperative testing for surgical procedures to improve the quality, reduce cost, and improve the equity of care delivered in Michigan. And we provided some reasons as to why we wanted to focus on this particular area. Dr. Danek shared some further evidence and also identified some of those particular tests that may become patient-specific, and talked a little bit about the work that's being done at Ascension Genesis to reduce preoperative testing in those low-risk procedures. Additionally, we shared some reports on our new COVID-19 service line, and we would really appreciate any feedback that you can give us on what specific details or information your facilities would like to be able to see within those reports. So to finish up, we'd like to share some upcoming engagement events with you. These are some of our work groups and our webinars that we have. We have Marquis presenting at the Joint Work Group on 11/12. We will be reviewing some upcoming sepsis reports at our sepsis work group on 12/8. We have Agency on Aging presenting at our chronic disease management workshop on 12/15, and Impact will be presenting at our congestive heart failure work group on 12/17. The call-in information will be sent out to the site coordinators about a week prior to the session. Our next semi-annual will again be a virtual on Friday, May the 7th, and we will be sending out more information early next year. You will, as Hari said, be receiving a brief survey after this meeting, and we really appreciate you completing that survey to help us with planning future events and identifying your needs. Alternatively, if you want to connect with the Coordinating Centre to provide any feedback, any suggestions, or any analytic or engagement requests that you may have, please email us at the email address on the screen. Thank you once again. Thank you, Dr. Katan. Thank you, Dr. Danik, and have a safe and happy Halloween.